the inner. This also has to be opened. This is the obturator. This is the stiff catheter which goes inside the outer if you are facing some negotiation problem. It is finer than the outer, so it is 4 French, 19 centimeter. Here, open this as well. So this is the outer. There is a slight bulb at the top. There's a guard. This is for us to hold it smoothly. And this can be adjusted depending on your assessment of the cervix, the length in which you, some have small cervix, so you can do it this much. Some have a large uterus, so you pull it down. Roughly it stays here. This is the inner, sorry, this is the obturator, which goes into the outer if you face any problem, and then you can stiffen it in various directions for negotiation. This is the inner. It has a metallic part, and this is the fine catheter. The embryos are loaded here. There are markings here which help us to know how much we have traveled inside the cavity. So today I'm going to show you afterload technique which we do for all of our patients. Can I have the light here? So as we have mentioned again and again, that we can have the torch if you wish, that cleaning of the cervix is very important. So we are now cleaning the cervix. You'll have to dislodge it and bring it here. Bring it from here. This is an important step and we must see it properly. So the speculum is in place, and gently with a swab which the saline is completely dried. Are you getting the view? Yes? Can you check if the view is coming? Right. And then with the syringe, a 1 cc syringe, we aspirate little bit. We go right into the external os and we suck out the mucus. You have to be very gentle. We have already explained how important this step is. And then finally, we take the swab sticks and just go to the external os and drag the mucus out. Don't push it in. Don't go in like this. Go right just beyond the os, hold the mucus and drag it out. Before that, we have taken the patient, we have checked whether the vision is fine or not. Can we have double screen? Double screen. And we see a wonderful vision in which we can see the cervix, the entire uterocervical length, and under guidance, light. We are putting the outer. And we just put it, see, if you see, this is the normal placement of the catheter, of the guard. But I can find the os here. as I go in. So I will push it up. I don't want this to go right into the cavity, just up to the internal os. And then in the afterload technique, I will just check whether my inner is going through. It is going, and I take it off and I hand it over to my embryologist. Focus here. Who will now load the embryos? Yes, please. So the embryologist, single please. The embryologist will not load the embryos till we have said load. So now you will see from my placement till loading till transfer should be less than a minute. And that is the critical double. She has loaded. Are we getting double view? Wonderful. And now I am passing. Can we see the inner? Yeah, you see the tip? Follow the tip always. Even don't lose it even for a second. Yes. And now if we freeze it here, freeze it and calculate it. Kiran, can you calculate from that point to the fundus? Point in the middle to the fundus. No. Here. Here or more less, little less, little less. Yes, about 1.3. Defreeze. So your maximum implantation point is about 1.3 to 2 centimeter from the fundus. And then you, if you can show on my hand also, just a jet. Push it. And then withdraw and hand it, freeze. And now the embryologist will check for any embryos which are remaining or not. And then will let us know that the transfer is complete. So she has told it's clear. Can I have the outer? So once it's clear, then you can tell the patient that the process is over. This is just to show you if there is a difficult cervical canal, the obturator goes in. And can I have the inner also, please? Light here. Can I have the on the screen? So if you focus here, defreeze. Focus on my hand. So this is just for demonstration's sake. The obturator has gone in. I can have single now. And then I have taken off the obturator and the embryologist has given me and I load it. So this is how. Now if you see markings here, can you have light here? With the torch. So if you see, there are the markings here. 1, 2, 3, and 4. So this means I have gone 1 centimeter into the uterus, 2 centimeter. So usually up to 2 centimeter is what we go and not beyond. All right, can we have the single? And can we have the next trolley ready? So now as we are preparing for the next case, so in which we will be showing you single, Kiran, please come here. in which we have shown one kind of a catheter. Next, we will show you a different kind of a catheter, which will give us the same purpose. So I have Kiran here, my expert embryologist. And as we all know, these steps are important, but embryology is, if not more, equally important. So in our last workshop, we did egg pickup, and now we are going to discuss about what happened after the eggs were retrieved till their transfer.
Thank you, ma'am. Hello, everyone. So once we get the eggs, like after washing it properly, we have to wash it in the media. So we have two types of media. One is sequential media and one is single step media. So we usually use sequential media. So we have to wash the oocytes thoroughly in the gamete buffer media. And then after washing, we have to put it in the fertilization media. After incubation for minimum of 2 to 4 hours, we decide whether we have to do IVF or XC. Once we did the IVF, we have to we have to prepare the sample and we have to do the in vitro fertilization IVF. If we are doing the IVF, we have to do it in the fertilization media. And the next day, we check for the PN status. So after checking the PN status, we have to denude the embryo oocytes and then check the PN status of the eggs and then put it in the cleavage media. We have to keep the oocytes in the cleavage media for minimum of 2 to 3 days. On day 2, they should be 2 to 4 cells, and on day 3, they should be 6 to 8 cells of stage of embryo. If we are doing the ICSI procedure, after doing ICSI on day 0, we can directly put them in the cleavage media and then check the PN status on day 1 and day 2, 2 to 4 cell stage embryos, and day 3, we check 6 to 8 cell stage of embryos. If we are planning for the blastocyst transfer, we have to change the media on day 3 and use the blastocyst media for if we are planning for a embryo transfer on day 5. And if we are planning to freeze the embryos, then we have to decide on day 3 or day 5, depending on the clinician, which they tell us. And if we are depending on the number of oocytes, depending on the number of embryos, we have to counsel the patient on the day of embryo transfer, whether we are transferring minimum 3 to 4 grade embryos. And if we have enough number of embryos, we have to give them the option of freezing also on the day of embryo transfer.
Yes, thank you, Kiran. So as we know, the embryology steps are very, very important. And in this, before we do the embryo transfer, we will have to be sure that we have counseled the couple regarding whether we want delayed transfer, cleavage stage embryos, how many embryos, risk of twin pregnancy, blastocyst transfer. All these should be explained before. And on the day of embryo transfer, they have come to us and we have said, well, we got these many eggs, these many fertilized, these many grade A embryos, grade B embryos, grade C embryos. Are we going to blastocyst? Not going to blastocyst? 1, 2, risk of multiple, how many extra or not, and freezing. So all these should be discussed before coming for the embryo transfer. Now we are going to show the usage of a different catheter. And this is more or less the same. And we will also again show the cleaning of the uterus and the insertion and the drop. So can we have the lights off? Yeah. Now we are going to show you, this is the other Sure Pro Ultra Embryo Replacement Catheter with Stillet. This is also 17 gauge and 6.4 French. Can you open it? Now you will see how different this is. So what's different about it? This outer has an inbuilt obturator. The obturator is just coming out of the tip and it has a smooth edge. So it may help you in negotiation. Again, you adjust your guard and you have the inner, and sometimes there are micro bubbles in the polyvinyl sheath of the catheter, which may help us in visualization. So let's see how we transfer this one. So I will again show you the cleaning. So can we have the light and the camera inside? So once I have cleaned with normal saline and dried it, you can use flushing media. Again, the syringe goes in gently at the os. Just check outside. And it is sucked out. And again, gently. And then the mucus is separated and pulled out. Sometimes we even use a sponge holder gently to bring out the mucus. And the inner, you can let me do the afterload. Just an angulation, because if it is antiverted, it can go like this. If it is retroverted, depends on that. I put it in. Double. Let's show the cervix. Yeah. Just at the level. Out with the obturator. Afterload technique. Checking. Hand over to embryologist. And they will load the embryos and hand it over to us. And again, as I mentioned, if you're ready this way, from the time your embryo is out of the incubator, the loading has been done in the catheter, you are ready, transferred to you, and you have pushed less than 1 minute. This is a trick, really. If you're struggling with your embryos out like this in the air while you are struggling here, then you can be sure the results will be very less. So don't do that. And now we are passing. We are going in. Can I see the inner? Yeah, wonderful. The drop and back. So this is the tip. If we can focus. Here we should not, can we have single? Here we should not see any blood. Should be as atraumatic. Though blood, again and again I've said, is not directly correlated to pregnancy rate, especially on the outer, but it should be as clean as possible. Follow the embryologist. Next patient. Okay, you can come here on the tripod. Manoj, you can come here. While we are getting ready for the next patient, see, I wanted to show you some ultrasound parameters. Now, if you see, here we have the gain. Now, if I keep it on the left, it is all white. If I keep it on the right, it is all dark. So better we have an adjustment like this. Okay, this is one. Then can somebody change the probe settings? Dr. Bhavna, you get. from there. This is at an abdominal setting. And if we go into the preset, just make it TBS. Then we get the TBS. Now back to abdomen. Yes. Now here I just wanted to show that suppose this is your uterus and you go to depth. You get it on here, you press enter and you get a bigger view. Or you want a bigger view, you zoom out. Whichever works for you. This is your darkness or brightness. And these are your measuring points. So you can measure from the internal os to the fundus. This measurement also you can take. Some measure it before doing the transfer. I do it when the visualization is difficult. I measure it. But now Kiran will tell about the loading techniques.
So, ma'am, basically there are two types of loading techniques. One is air fluid group and one is fluid only group. So in air fluid group, we have to take at the proximal part of the inner, we have to take around 5 to 10 microliters of, we have to aspirate air, then go into the dish, embryos. We have to aspirate the embryos with the media around 5 to 10 microliters and then take out the inner and secure it with the air gap, which is air fluid group. In the second thing, we can do fluid only group. We have to flush the inner with the media, then the inner is filled with the media and then directly go into the dish containing the embryos, pick up the embryos with the media and secure it with little bit of air at the proximal part and then hand it over to the clinician.
Now, as you know, there are, as we were discussing, small uterus, arcuate uterus, multiparous uterus, fibroid uterus. So your point of drop cannot be 2 centimeter or 2.5 centimeter for every case.
Every case.
So one is you have already assessed your patient, you know the uterus length, and you know during stimulation the uterus may become a little bigger. The second is what used to happen in the pre-ultrasound era. Before stimulation, they used to do hysteroscopy and they used to measure the uterocervical length. And they would know whether it's 3 centimeter, 2 centimeter, etc. And then the next would be the transvaginal way of measuring. So now we are going to demonstrate the transvaginal way of doing the embryo transfer. I hope we will be successful in it. We have done it for very difficult patients, either obese or a big scar or visualization not good, and we want to be sure. So in these cases, you can even do the measurement technique. You do your TVS. So let me just run you through the measurement technique and then try to translate it into the TVS technique. So what catheter are you giving me today? Okay. So this is the Guardia and apparently it has an eco tip. And with the eco tip, we are going to be able to visualize the tip better. And I hope we get a good drop so that we are able to show in the TVS. Can I have the, you can open it and can I have the TVS? Open it. So this is the sagittal view. double, and as we can see the entire uterocervical length. So if I am not able to see transabdominally, I freeze here, go to the point of the internal os, come to the mid cavity. So I know roughly 2.2. So if my external is at the level of the os, I know I have to go in roughly 2.2 centimeters. So for those who missed last time, quickly I want to run through to TVS. This is the way my hand is. The probe angle is in the front. And I can see this is the angle in which you should measure the endometrial thickness. Not in this, not in this, not in this. You should be able to see the entire uterus and cervix. And then we do transverse and we go up and down. And in this plane, you are able to see various uterine defects. And in the sagittal view only, you go up and down and you'll see your ovaries on one side. If my hand is to the patient's left, I'm seeing her right. And if it is to her right, I'm seeing her left. And it is in this plane that we pick up hydrosalpinx, ovarian cyst, and things like that. Okay. So now I'm going to do the transvaginal technique of embryo transfer. Relax. The same steps really. Table up. I don't know why it's up and down. Thank you. Okay. Just the cleaning. All right, now I shall put in the outer. Need a stylet? Single. It has gone in. I take it out. You can load the embryos. And I gently will take out the cervix. Gentle. And I will put in the transvaginal probe, hoping that while we took it out, it didn't slip out of the on the TVS. Double. I don't know if you can see. I think you are. This is the trick in the vaginal. While you are taking out your single on me, your speculum, you may dislodge your outer. So that seems to have happened. It is a practical problem. Take it out very slowly. We shall try it once more. And if it does not work with this time, we will in fact use the SIMS. इसको पकड़ो, मैं निकालूं। अंदर पुश करके रखना। Very slowly we have to take it out. Push it, continue to push it. Hold that thing there, push it again. Hopefully it has stayed in its place this time. Let me check. What is it doing? Yes, we are in place. And now I will ask my embryologist to load the inner, which she has. Are we getting the double view? Double view. So this is for those cases where, you know, it is impossible to get an abdominal view, multiple failures, and you want to be sure where you are putting your embryos. Now this is an interesting thing. It is going slightly into the subendometrium. So I'll withdraw, advance the outer slightly. Let's see how the bubble goes. For demonstration, it is gone. I hold it, take it back, leave the TVS there only. This is a patient with a difficult endometrium. And the droplets are here. Freeze it, freeze. Right. So it is clear. Now here I want to touch 2-3 points. So this is for the demonstration's sake. What we found is that to put in the outer and then to take out your cuscos can be difficult if you don't do it gently. For that purpose, you may have to advance the outer a little bit beyond the os to be able to, for it to be in place, and then guide the inner. The other thing is, if you don't reach the mid cavity and the drop does not go mid cavity and it is a little subendometrial, then there are the various techniques that you have to use. One is you angulate the angle of the outer, so that instead of the outer going down and touching the subendo, it is going up and it is going in the cavity. And the other is what the academicians discussed in the discussion, is hold with the anterior lip, either anteriorly or posteriorly, and pull the uterus so that your inner doesn't go at this angle. At the end, your drop has to be in mid cavity, central position. So Dr. Parul and panelist chairpersons, as we move on to the next questions, we can take your queries. Break. So we know that IVF is still not reached the stage where we can have 100% results. And my appeal to all ART centers that we do such voluminous work, please maintain data and translate it into research work so that we can also say. So we have said traveling makes no difference, anesthesia if required makes no difference, study protocols are endometrial preparation protocols are almost the same. So in most of the cases, we are using simple protocol of frozen embryo transfer, starting day 1, day 2, and giving estrogens for about 10 days, seeing whether a lead follicle is coming up or not. If it is coming, give HCG and then give progesterone. Otherwise, once your endometrium is right thickness, you start progesterone. And depending on day of transfer, you do a day 2 or a day 3 or a day 5 transfer. And the beginning point is very important. If you start when the E2 is not low, and E2 low can be said by a transvaginal scan where there are no cyst, no follicle, endometrium is thin. No need to do any blood test, just start your preparation. But if there is a doubt, thick endometrium, cyst here, do your E2 levels. And if they are less than 80, preferably less than 50 picograms per ml, only then we should go ahead with the endometrium preparation for that cycle. Now we are going to a very interesting case, and let's see if our delegates will be able to pick up. So first, let me show you the Labotech outer. So if you see, this is the difficult transfers, where you need something more firmer than a soft and an obturator. So this is metallic, but it is malleable. Outer. Open, please. Inner. And it will be threaded in. Okay. So now again, we start with the steps which are crucial. Relax. Just cleaning. Okay. So there was a question whether we can use flushing media for cleaning, and the answer is yes, you can, and many centers use only flushing media. Can I have a normal outer, please, first? Double. Can I have the screen view of the abdomen? Okay. So if you will watch the screen, I am now going to make it a little bit more clearer, and we must always start with a simple catheter to see whether it is negotiable. It's going up to a point but not beyond. So again, can I see the uterus? Yeah, there is a notch and my outer is going down. So I have to correct the angulation. I put in an obturator, get the angle so that I can go up. Need to see the cervix. Okay, just show like this. And now I'll check whether it has gone or not. Yes. Can you load? So we will check this. I'll do the transfer here. I will use the Labotech to guide how to do when there is a Labotech. And then we will empty the bladder of this patient and do a TVS to show you what we are dealing with. Right, so this was one example. Now the negotiation was with a simple one. Now if we were unable, then I would have used this one. And you see how clearly it is visible. And I thread in. So always in difficult cases, keep this ready with you. Keep your stylet ready. And keep your Labotech ready. So if you see, can you zoom into this? Where there is cervical stenosis, where there is isthmic, isthmocele, cysts, crypts. That is the thing in most. Can I have the other outer? But in 90% of cases, the Cook with the obturator and the Wallace with the obturator. If we are talking about, can we have the Wallace with the obturator? And this is the Cook with the obturator. Difficult transfer. In 90%, this angulation, this movement, this will help you guide. And then you need to stay steady. And that is what is going to help you negotiate. So as she comes back with an empty bladder, we will have some discussions. Thank you. We have a few questions which I will be taken. One is, does hysteroscopy increase the chance of the success? Usually to be avoided in the same month, but if you can do it even in the next cycle, if you're planning the second cycle. Now we have Puma with us. She's a senior nurse. And as we have said, that embryo transfer is a difficult, stage and steps. Everything has to be followed. So I would like to have you all to have a viewpoint of what is the nursing staff's duty for our embryo transfer patients.
Hello, this is Puma. Hello, this is Puma. I just want to highlight how we ready the patients before and after embryo transfer. First, we receive the patient, we change the patients and take them to recovery room. First, we check the patient's identification. Then ask the patient if their bladder is full. Then, if possible, we ask them to empty half. And after that, we take the patient to OT in lithotomy position. During the embryo transfer, we are with the patient by holding their hands to give support and ensure safety. After the embryo transfer, we shift the patient to recovery room, offer some water, juice, tea, or biscuit. After 30 minutes of embryo transfer, we encourage patient to empty the bladder. If patient refuses, then we offer bed pain. Lastly, but not least, as the patient discharged from the clinic, we just wish them good luck. That's all. Thank you.
Thank you, Puma. So you see, right from there, coming into the recovery room, going on to the ET table and sending them back home. The entire team must be with them. Now, as we are going to get ready for the TVS of the last patient, to find out from the delegates if they know what kind of case it was, and it appeared a simple negotiation, but it actually isn't. You would need to practice. So let me just do the TVS and then you can say, before the patient gets ready, let me take you to the lab and Kiran will be showing you embryo loading.
I'll be showing you the two torch are enough with the syringe attached. So I will be showing you the air fluid group first. So we have to first take a little bit of air. Then this is the dish. We have to identify the name of the patient. We have to confirm from the clinician. So we have the embryos here. We have to go into the dish containing the embryos. Aspirate the media along with the embryos. Around 5 to 10 microliters. Then secure it with little air gap. And then we hand it over to the clinician. So it should be less than 0.5 ml. And then we hand it over to the clinician for the transfer. The other technique is the fluid only group. So this is the dish. We have to aspirate the media first. We have to flush the catheter with the media. Fill it with the media. Take out the plunger. Sorry. Take out the plunger. So the catheter is filled with the media now. Go into the dish. Take the media. Take it out. Secure it with little air gap at the proximal part. And then hand it over to the clinician for the transfer.
Right. So these are the two techniques that we are following here. Air, media, air and fluid air. And depending on who is comfortable with what we are doing, if we will focus, we have two unfertilized oocytes here. And we are just going to show you under magnification how these are picked up by the embryologist. So it's a very fine work, and embryo transfer has to be done by one of the senior people in your team. And you have to be as gentle by loading as with your transfer technique. So really a successful IVF is a team effort. So now, thank you, Kiran. And now let us go back to our previous patient and let us see what the TBS findings are. Double Lights off. So this is one uterus. You want to increase brightness? And I go transverse. Just if you see below at one plane. There is another horn. Freeze. So she's a unicornoid with a non-communicating horn. So why I was keen in showing the TVS of this patient is this is the uterus where we have done the transfer, and this is the journey that catheter has traveled, and this here is one another horn which is non-communicating, but sometimes these can create problems during your negotiations, and in such patients you must transfer only single or maximum 2 cleavage and not higher number of embryos. So as we are in the conclusion of this, I would like Kiran to come here and explain a little bit about cryopreservation. Yes, Kiran.
Hello, everyone. So, as I've told earlier, like if we have to do the freezing, we do either it on day 2 or day 3 or day 5. So this is the cryolog. This is the straw.
Light. Can we have the light, please, and focus here?
So this is the straw in which we do the freezing of the embryos, either cleavage stage or the blastocyst. So this is the straw in which we do the freezing, either the cleavage stage embryos or the blastocyst embryos. So we have to take out the media ahead before doing the freezing process to equilibrate the media, and then we do the freezing. We have to do the equilibration of the media first, then make the droplets at the room temperature. Room temperature is very important for the vitrification of the embryos and oocytes. So this is the device. Once we do the freezing, we have to load the embryos into the device. As you see, on the tip, there is a black mark. This is the covering of the cryolog. We have to take it out, load the embryos at the proximal part of the tip of the straw, and then directly plunge into the liquid nitrogen and cap it. After capping it, this is the holder, this is the goblet, which is kept into which is already equilibrated in the liquid nitrogen media. So these, you can see there are multiple colors, different goblet. So we have to put the straw inside the goblet, and then we have to note it, like for blue, we have to note it into the records that for this patient in this cryolog, we have to mention all the details on the cryolog. We are putting it in blue goblet and then register into our register, and then put it back in the liquid nitrogen into the canister.
So what is the technique used and the media used for cryopreservation?
It is we use the Kita Zato media. So there are two types of media in that. One is the equilibration media, one is the vitrification media. For the oocyte and the embryos, we usually around for 10 to 12 minutes. For oocyte and cleavage stage embryos, we have to keep the embryos in the equilibration media. This in that media, like once you drop it in the droplet, after 30 seconds, they will fall on the base of the media. And then after 10 to 12 minutes, they will regain its shape. And then in the vitrification media, we have to be very quick. Within 60 seconds, less than 60 seconds, we have to wash the oocytes or the embryos thoroughly in the vitrification, multiple drops of vitrification media, and then load it into the straw and directly plunge it into the liquid nitrogen. So all this has to be done in less than 60 seconds. And if you are doing the blastocyst, we have to keep it in the equilibration media for minimum 12 to 15 minutes.
Thank you, Kiran.